Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And joining me, as always, from the racing capital of the world, Indianapolis, Indiana, is my good friend and co-host, Ben Blanc, our Director of Digital Production and Engagement at GHLF. Ben, we're in mid-May. We're gearing up for Indy 500. What's going on in Indianapolis?
You know, you really can't escape it here. And the traffic cones are everywhere, the checkered flags are everywhere. The whole city's buzzing. And next week, I can tell you, during the race, I'll be able to hear the cars from my house all the way from Speedway. But anyway, while the Indy 500 is all about speed and performance, today we're actually looking at something that could hit the brakes for patients. Recent drug pricing rules that might sound good on paper, but that could create real-world barriers to care.
It's a good point, Ben, and we're going to dive into some new research that we released through the Global Healthy Living Foundation.
And that brings us to a new peer-reviewed publication you recently co-authored, Robert, published in the Journal of Health Economics and Outcomes Research. So let's get into what the study uncovered and why it matters for patient access. All right, today we're discussing a recent report titled, Could the Inflation Reduction Act Maximum Fair Price Hurt Patients? The paper digs into whether this new pricing mechanism designed to make medications more affordable might backfire and actually make it harder for some patients to get the treatment they need. So let's start with the basics. Robert, the Inflation Reduction Act, the IRA, it introduced something called the maximum fair price for certain medications. Can you explain what that is, how it's supposed to work, and what concerns led you and your co-authors to explore this in your new report?
Well, Ben, we've spoken about IRA, Inflation Reduction Act, multiple times on this podcast. And just like any other complex legislation, there's some good, the bad, and the ugly that's involved in it. And one of the ugly parts is the price setting by the federal government of drugs based on utilization and spending. So the federal government decided through IRA that they were going to pick drugs on Medicare spends the most, not necessarily the most costliest drugs, but the ones that they spend the most on, and try to price set them at a level much below than what they are. Which is like, look, theoretically, it sounds great. And one of the selling points from the administration, and this is the Biden administration, was that we will be able to lower the prices and patients will pay less out-of-pocket costs and will have better access to these medicines. And that's why we need to pass legislation. But one of the unknown consequences is that the way that the system in the United States is set up, which is the rebate system, the way that it works is pharma companies have a price for them to be able to get coverage through formularies, whether it's Medicaid, Medicare, commercial. They have to pay rebates to these entities for them to cover their medicines. And the higher the price, because rebates are a percentage, the higher the rebates. So in essence, PBMs, insurers, Medicaid programs make more money on rebates and kickbacks if the price of the drug is much higher. So by suppressing the price, which is the top line, what you're doing is that you're reducing the revenue or the profitability for these entities like the Medicaid programs or PBMs. In essence, we're not opposed to that, right? In GHLF, we don't care if PBMs are making less money. And in fact, if the government is making less money off of patients' pockets. But the problem is that they're not going to just stand pat and not do anything. They're going to want to make the difference in the lost revenue or profitability somewhere else. And one of the things that we hypothesized in our study, and we did it through modeling, is that perhaps what the PBMs will do is to shift the drug to a higher tier. That means by going a higher tier formulary, patients are paying more out of pocket. Or even within the formulary tier, they may shift the patients to a higher out of pocket cost and therefore try to recoup some of that profitability back from losing that. So by doing so, there are consequences that are going to happen, and we can get into exactly what we discovered in the paper and ended up basically being published. And to us, it's very important research because, Ben, nobody else has done this. And we were able to use primary data with regards to out-of-pocket costs instead of modeling or anything else. And therefore, we were able to actually estimate what will happen if the out-of-pocket cost increases and how patients will react to that.
Thanks, Robert. And that's really a great explanation of how the policy works in theory. And you talked about the rebate system, but your report takes it actually a step further and models what could happen in practice. You actually just briefly alluded to modeling. Now, let's get into the specifics of that because your paper actually focuses on two anticoagulants, Eliquis and Xarelto. So let's talk about this. Why those drugs specifically, and what did your model show about how cost increases could lead to patients stopping treatment?
The two drugs, Eliquis and Xarelto, that we chose actually are in the list of the first 10 drugs that the federal government decided to set prices on. And both of these drugs are known as anticoagulants. They're commonly used especially in elderly patients. Its high utilization is older patients because it's commonly used for things like DVT, deep vein thrombosis, for atrial fibrillation, things like that, such nature as a disease area. So, as you get older, incidence of DVT and AFib go up. So those patients utilize it quite a bit. So we decided to use those two drugs because, one, the federal government chose them to be price set. Number two, a lot of people utilize these medicines, especially in the Medicare and the elderly population. And the third is that there are significant consequences if patients stop taking these drugs if they were on them. They are taken chronically usually. And if you stop taking them, there are significant negative outcomes that can occur. So we chose to look at these two specifically among the other 8 that also will have different sequelae or effect if they are impacted with regards to the same observations that we gathered.
Yeah, thanks, Robert. And from the report, those numbers are staggering. And actually, for our listeners, we'll drop the link to the full paper in the episode description. They can take a look at those numbers. We know that these aren't just financial decisions. When patients abandon treatment, the consequences can be life-threatening. So, based on your findings, Robert, what kind of real-world health outcomes like hospitalizations or death could we be looking at if access is disrupted?
So Ben, there's clear evidence when out-of-pocket costs go higher for patients start abandoning therapies. So imagine you have a drug like Eliquis, the price is suppressed by the federal government, PBMs make less profit. In essence, to make up for that difference, they increase the out-of-pocket cost for patients. Patient goes to the pharmacy and now has a higher out-of-pocket cost and ends up not picking up the medicine and discontinues therapy. So non-compliance becomes an issue. Now, in case of Eliquis and Xarelto, the consequences, as I said, are severe because if somebody abandons therapy for those two drugs, the consequences tend to be strokes, MI, and death. And there's a lot of evidence out there with regards to published literature in randomized clinical trials and also clinical trials that demonstrate two things. Number one, increasing out-of-pocket costs increases non-compliance, abandonment. The second thing with regards to Xarelto and Eliquis, there's direct evidence that if you stop taking your DOAC, your anticoagulant, and you're a patient that is at risk and you're taking that drug chronically, there's a significant higher incidence of strokes and MI and mortality, and that has been documented. So because of that, we could model, right? So we knew what the out-of-pocket cost was for these drugs because we were able to acquire this information from the manufacturers. We also knew that if we shift a certain percentage of patients to a higher out-of-pocket cost, what would be the abandonment rate? And because the literature, as I said, has documented information about what the consequences would be, we were able to model out how many patients would suffer an MI, a stroke, and unfortunately die. And it's very similar to other type of instances that have been documented in papers where increasing out-of-pocket costs eventually leads to non-compliance and poor outcomes for patients.
And Robert, the modeling that you did brings us to a bigger issue, transparency, because understanding where these costs land is anything but clear-cut. So why is it so hard to get accurate data on drug prices, rebates, and what patients actually pay? And how does this lack of transparency make it difficult to protect patients from cost shifting?
The lack of transparency is intentional. Pharmacy benefit managers benefit, no pun intended, from lack of transparency because the more they keep the data hidden from entities such as patients, providers, employers, so on and so forth, what will happen is that as the patients go in and try to get medicines, they're surprised by their out-of-pocket costs. They make more money by secrecy. And that's why it's called the black hole or the black box that nobody knows about except for the pharmacy benefit management companies. So that's why it's so hard to get what the prices are, what the net prices are, what the rebate levels are. And the argument has always been from the PBM industry is that if we provide this information, there will be lack of competition, which is poppycock, as they say in England. The reason being is that there's plenty of evidence in the marketplace, and even with pharmaceuticals, when competition occurs, the prices are suppressed. And no matter whether you're transparent or not, just we've seen with the biosimilars, with regards to the net pricing, that the prices do become lower and lower and lower, and patients benefit from it. But that's why it's so difficult. It's the pharmacy benefit management companies, the way they've set up the system through the rebate contracting, which they have sort of bamboozled everybody, whether it's a policymakers, employers, that is the only way that they can contract with pharma companies. The reality is that, as I've said this multiple times on this podcast, the largest state in this country, California, the largest insurer in the state of California, Kaiser Permanente, does not use rebate contracting as a methodology to work with the biopharma companies. Instead, they use net price contracting, and patients directly benefit from the negotiated prices. So this whole issue of that we cannot do it any other way but the current model, which hurts patients, is not true. And we can have a more transparent, more equitable model of net price contracting similar to what Kaiser does, which benefits patients directly.
Well, talking about being equitable, given everything that we've discussed, it's clear that these policies need to be closely watched, and not just by economists, but also by policymakers. So here's my last question for you, Robert. What steps should CMS or policymakers be taking to track the effects of these new policies and to make sure patients aren't the ones bearing the burden of cost savings measures?
What they should do is be able to follow out-of-pocket spending for seniors on these MFP drugs. Remember, the promise from the Biden administration was when the passage of IRA occurred that patients would pay less for these drugs and they will have equal, if not better, access. So it is this responsibility of CMS, which has the oversight of the insurers and PBMs, to ensure those promises are met and kept. So they need to not only make sure that the products are still on formulary and they have adequate coverage, but they also need to require that the PBMs support that the patients are not paying more out of pocket for these medicines and that in fact their access has been retained and they don't have to jump through multiple hurdles. Now, one of the things I will tell you is that we have released a tool now from the Pioneer Institute that tracks that for the MFP drugs, and we're going to drop the link to that tool in our show notes. But this is a very good complement to our paper because our paper looked at what happens if you move the out-of-pocket costs for these seniors for these MFP drugs, these drugs that have been price set, and what the consequences are if the patients start abandoning therapy. And the Pioneer tool confirms or demonstrates what the out-of-pocket cost increases have been in real time. And we are both using data that has been validated. This is not some modeling information that has been validated regarding out-of-pocket costs. So in essence, CMS is the responsible party here. Now, Ben, whether they do it or not, it's a different question for two reasons. Number one, do they have the bandwidth? With all of the changes going on in the Health and Human Services Department currently through the Trump administration, do they even have the personnel to be able to do such thing? And the second question is, do they have the stomach and the ability? They probably have the ability, but do they have the stomach to look at this information? Because as we're seeing through our research and through the Pioneer Institute tool, which I'm involved in, patients are going to pay more and there are consequences for those out-of-pocket cost increases.
Well, thank you, Robert, for breaking down the findings of this paper. And we'll drop, of course, a link, as I mentioned, to the full paper in the episode description. So, Robert, my main takeaway from everything that you said is that the IRA, the Inflation Reduction Act, was designed to lower costs for seniors. But if pharmacy benefit managers shift the burden, patients could end up paying more out of pocket. And that's not just a financial issue, it's a public health one. And that's why we talked about policymakers and the importance of transparency and patient protection to ensure the benefits of these reforms are truly felt at the pharmacy counter. But I'm not the expert, so Robert, you have the last word.
You probably did a better job than 99% of experts out there, the so-called experts, to explain the situation. And, at the end of the day, seniors depend on drugs to keep them healthy and alive. And if the government has taken a step to set drug prices lower, and those lower prices lead to less profitability for PBMs, then that's a good thing. But if the PBMs turn around and then increase prices on patients that are taking these medicines, make them less accessible, then that's a bad thing. And CMS and the government has a responsibility to track this. Now, we're very proud that this is a one-of-a-kind study that we've done. We've published it in a peer-reviewed journal. This is not some fly-by-night report from some public affairs agency. We're very proud of our research, and we stand behind it. And everything that we've done so far is being confirmed by alternative research that's being done, including the work I've done real-time looking at out-of-pocket costs through the Pioneer Institute. So this is not a unique situation also, Ben, just for these two drugs of Eliquis and Xarelto. I truly believe that every other MFP drug will have significant issues with regards to access because of this increasing out-of-pocket costs that will occur because PBMs are going to feel the pressure of filling the void from the profitability that they're going to lose. So we need to do both. We need to lower prices, improve access, but at the same time ensure that PBMs are not playing games and disenfranchising patients.
Well, thanks so much for breaking that down for us, Robert, and thank you all for listening. That wraps up today's episode, so don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you might be listening so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It will help more people like you find us.
If you have any questions, thoughts, or suggestions, please send us an email at podcasts@ghlf.org. We're always looking for new information, new thoughts, new ideas. And frankly, if you have thoughts and ideas about IRA, our research, the pioneer work that I've been involved in, and any of the other topics with regards to drug pricing, access, and affordability, please reach out to us, and we'll be more than happy to feature you in one of our upcoming episodes.
And before you go, make sure you take a listen to some of the other great podcasts on the GHLF Podcast Network. You'll find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
And he's Ben Blanc. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.